We will straight away move on to the topic proper. And Ischemic Heart Disease patient for knee replacement. It's my hospital. I am working in NeyyarMedicity hospital. We know that around 1.8 arthroplasty procedures are performed each year worldwide. In the sense, it's a huge number of arthroplasty is required around the world, even in America or in the European countries, wherever you go. And it's very prevalent that the knee replacement surgeries are done. Regarding the indication, in India or in our Kerala also, we have a plenty of knee replacement surgeries are done. In our trauma and orthopedic center, we also have every week we have at least 4 or 5 knee replacement surgeries are going on. And regarding the indication wise, the grade 3 and 4 OA, that means the knee space between the tibia and femur is obliterated. And with the weight bearing, they can have some spaces with weight bearing. They can wait for the knee replacement. Otherwise, grade 3 is a clear indication for knee replacement. 4, of course, the subluxation of the knee. Then, of course, the limitation of activity and requirement of daily analgesics. The pain and patient's limitation is the key in replacement. And why we need a total knee replacement in IHD patients? Factors that exacerbate the risk of cardiovascular disease. It's a raised blood pressure, poorly controlled diabetes, smoking, high body mass index, increased stress. But as far as we are concerned here in total knee replacement is concerned, the increased stress and non-steroidal drugs and underlying inflammation and physical inability. These are one of the major causes of my cardiovascular diseases. Along with the high blood pressure and the diabetes. Functional limitation due to arthroplasty, osteoarthritis, increased mortality is seen in cardiovascular causes. NSAID use increases psychological stress, also the major causes. And what are the benefits actually? Around 40% reduction in the subsequent risk of serious cardiovascular events in patients who survived actually. So total knee arthroplasty has a proved benefit for improving patients' pain, mobility, gait, and quality of life, and overall function is improved, and reduce the risk of serious cardiovascular events by relieving pain and psychological stress. Moderate intensity physical activity, for example, the brisk walking a few days a week has direct benefit on hypertension and obesity. So overall, increased mobility is increased, and overall psychological and stress factors are relieved. And of course, the physical activity, we can recoup the physical activity. That is the major physiological and psychological relief for the patient. And of course, other comorbidities start a better control with this. So we move on to our case. It's a 72-year-old lady, known case of systemic hypertension, 30 years, on telmisartan 40 milligram OD and atenolol 25 milligram BD. History of coronary artery disease 5 years back when she underwent PCA to LAD and left circumflex artery. Currently receiving aspirin 75 milligram OD. Bilateral knee osteoarthritis with severe functional limitation due to pain. She gives no history of orthopnea and paroxysmal nocturnal dyspnea. So we decided to post for the left-sided total knee replacement, even though he has got a bilateral osteoarthritis. Maybe left side is more affected, or maybe decided to do it in 2 sittings. First do the left side or next to the right side. On the evaluation portion, the weight is around 54 kg. Patient is having anemia, and BP is raised 160/100. Pulse rate is 65 and very adequate. The patient on stent, actually this is a case of post-PCA patient. So the post-PCA patient undergo elective cardiac surgery. Of course, the bare metal stent is rarely used, and we use a drug-eluting stents here. So less than 3 months, surgery should be delayed, and 3 to 6 months is a preferable class 2B. And of course, more than 6 months is the time for the discontinuation of double antiplatelet therapy, and we can proceed with surgery. But Even in knee replacement, it's a highly elective surgery. We usually go with hernia. Not perform the test unless it is useful. Investigate and treat as if not undergoing surgery. This is the classical understanding of the preoperative evaluation in any patients, even though it's a cardiac patient for any elective surgery. No need of useless tests and investigations, even if investigate and treat as if not undergoing any surgery. And we will move on to the preoperatively, how we optimize the patient, and then we will consider the intraoperatively and the postoperative management. And this case, and I will consider it as how I will do on a regular basis. Regarding the preoperative evaluation, the functional capacity is difficult to assess because we know that bilateral OA with limited activity and all. Of course, patient is having anemia also, so the functional capacity assessment may be a big problem. Anyway, we expect a metabolic equivalence of more than 4. Investigations wise, normally it's recommended that ECG is not recommended on a routine basis, but here this is a clear case of high ischemic heart disease, so ECG is definitely indicated. And guideline says that the ECG is indicated in intermediate and high risk patients. So this is considered as an intermediate or a high risk case, so we need ECG. Echo, of course, we need an echo evaluation for the ejection fraction. Of course, the aortic valves may be calcified, stenotic aortic valves may be there. And of course, regional wall motion abnormality status we have to assess. And if symptomatic, of course, we need to do the stress echo or of course thallium for the regional wall motion abnormalities, but it's an expensive one and it's routinely we are not doing. And the main thing is that it's a highly elective surgery. So if it is a symptomatic one, then normally we don't take up this case for knee replacement. So this is not a symptomatic case, and we investigated with the ECG and echo evaluation. And optimization portion, major optimization we have to do is for the anemia portion and of course hypertension. So whether to continue or antihypertensive or not. Anemia, of course, that we don't have a clear-cut transfusion trigger actually, but general consensus is that the hemoglobin should be more than 8, and the guideline says that it should not be less than 7, and it should be more than 8. Is not that is not recommended. Its recommendation is that it should not be less than 7. So we'll keep it more than 8. Antihypertensive portion will stop the telmisartan. Actually, the patient is getting telmisartan. We should stop the telmisartan 24 hours prior. The point is that actually we may have an intra-op hypotension, uncontrollable hypotension may be there, and of course the response to inotropics and agents and vasopressors may be difficult. So we will stop telmi and continue. Any beta blocker is we will continue the beta blocker, and of course if you are starting the beta blocker for the better control of hypertension and heart rate, then it should be started 24 hours prior. Of course, the consent, we need a consent, and we should explain the procedure to the patient and exactly what is going on. And of course, the major thing is that we should, an anesthesiologist has to discuss with the patient regarding the postoperative pain management. Of course, the pain score assessment, and you should guarantee that how we manage the postoperative pain. And that is very important because they may have a big concern, and somebody in their family might be saying that it's a very painful procedure and all in the postoperative. So, and we will discuss how we give the postoperative pain management. We will discuss it later. Anyway, we'll arrange blood because the hemoglobin is lower, of course. So, surgical checklist, of course, that's very important because that's a WHO checklist. I am not going into the details, and we should confirm the side. That is very, very important because which side we are doing. Any orthopedic procedure, that is very important. Antibiotic, we'll give it around 60 minutes prior. A normal regular antibiotic in our institution we use as a cefuroxime 1.5 gram plus ticoplanin 400 milligram. Cefuroxime we will continue 3 times daily with 750 milligram into 3 days, and take a plan in after 12 hours, we give you an additional dose. That's all. And the bone implantation syndrome, we'll come to that later. Intraoperatively, we have we use anesthesia technique. My technique is a subarachnoid blockade plus ultrasound guider, either tibial nerve block or IPAC plus continuous adductor canal block. And of course, we need a monitors. Actually, the ECG monitor, slowly ECG monitor is recommended, or at least V5, V6 monitoring ECG, continuous ECG monitoring should be there. IV fluids, it's a goal-directed therapy of IV fluids, either linolactate or plasmalite, and anemia. Anesthesia, of course, we give a lumbar spinal subarachnoid blockade. Normally, I give it's around 70-year-old lady with 54 kg. I will give around 2.8 or 3 milligram, 3 ml of 0.5% of bupivacaine heavy. Either if it is hemodynamically and BP is stable and all everything, I will give a clonidine may be added, or otherwise fentanyl is added. Because depending of that also is depending upon the surgeons, whether some surgeons we finish it in 1.5 hours and someone will take around 3 hours plus. So the salt anesthetic technique is lumbar spinal blockade. So we need to plan for at least 3 hours surgery. And of course, immediately after spinal anesthesia, what I do is that previously I do is that I give a tibial nerve block, and we will discuss it later. What are the importance of tibial nerve block and knee motor sparing blocks? We will discuss it later. Or a tibial nerve block or an IPAC we will give. Then oxygen supplementation and sedation once the anesthesia is set. Of course, the tourniquet, that also is depending upon the surgeon. Some surgeons do it under, entire procedure is done under tourniquet. And some surgeons will do it just prior to the replacement. They're putting the implant, they will tourniquet, and that is controversy. But in our center, they use tourniquet. And of course, the tranexamic acid, that is, we use around 10 to 20 milligram per kg of tranexamic acid. Maximum of 1 gram of tranexamic acid is given. That also is depending upon the surgeon's choice. That normally we give just prior to the release of the tourniquet, and normally otherwise the recommended is that just give it prior to the surgical incision. You can give 1 dose of tranexamic acid. Semen curfew in the sense that is a bone implantation syndrome. We can expect here in bone implantation syndrome in hip surgeries, and of course the total knee replacement. We are using around 40 grams of Siemens. So that is the semen implantation syndrome. The clinical features are the hypoxia, sudden loss of arterial pressure, pulmonary hypertension, and arrhythmia, loss of consciousness, cardiac arrest. And it's graded into grade 1, 2, and 3. And 3, of course, is a cardiovascular collapse. And the pathophysiology is not clear, but it is two pathophysiological models are there. Is embolic model. That means microembolism of that's a snowflakes, furies of fat and marrow semen. We can see it in this is snow furies in transesophageal echography. Multimodal model also, that is maybe is a complement activation and all. Anyway, that is clinically we are seeing it. Identification of the patient, at-risk patient, you should be identified, and increasing age and significant pulmonary diseases. And of course, the diuretics, patient on diuretics is a high chance for the bone implantation syndrome. And preparing the team in the sense, we have a semen curfew. I'm not going to the details of the semen curfew because just prior to the cementing, surgeon has to inform, and the timing we should mention semen fixation and semi-salt form. We have to fix it, and we have to have a clean anesthetist should be informed, and we have a close watch on the hemodynamic status when putting the cement. And of course, the systemic blood pressure, our practical point, we are keeping it around 20% high, and volume should be adequate. Treatment, if there is a cement implantation syndrome, 100% oxygen, fluid resuscitation, vasoactive or inotropic agents. Sometimes we need, if there is collapse, cardiovascular collapse, ACLS. And That is, and it's a good article on our WFSA, that's a cement implantation, in a tutorial of 351. So that is about the cement curfew and the tourniquet release. Just initial surgery is over, entire the procedure is over. We'll just release the tourniquet, and here also you should keep a close watch on the hemodynamics, because of the when the tourniquet release, we can expect hypertension and all. And in what we give is that just prior to the 15 minutes prior, we give a tranexamic test also. And the adductor canal block and catheter. Just before the patient leaves OT, what we do is an ultrasound guided adductor canal block and keep a catheter there. And the postoperatively, we keep it in a surgical ICU. And of course, the monitors has to be continued, because we can expect ischemic changes. We expect some ischemic changes. So it should be a very close monitoring of the ECG, and saturation should be monitored. Oxygen supplementation is a must in especially IHD patients. And the pain score is very, very important, but should be kept. What we do is that it's kept less than 3. And what we do is that continuous adductor canal block with the ropivacaine 0.5% and fentanyl 100 microgram we added in and around 100 ml of this thing in either in the elastometric pump or infusion we start around 5 ml per hour. Of course, the multimodal analgesia we need, and the DVT prophylaxis we have a mechanical intermittent pneumatic compression devices. And of course, low molecular heparin we start around 6 hours after. We know our institutional protocol is start with the enoxaparin 40 to 60 milligram. Here I will start with the 40 milligram of subcutaneous OD after 6 hours after the surgery. And some cases we start with rivaroxaban also, or we start oral feeds and the medicine, that especially the hypertensives, antihypertensives. And of course, the blood transfusion is needed. And night sedation is very important, because especially aged patients in the night, unless they got a good sound sleep, it's very annoying and distressing situation. Analgesia strategy for physiotherapy. That means that what we do is that in the evening, sometimes they will do some passive movements. Otherwise, normally we do in the next day morning, some passive movements. That's the first physiotherapy is very painful condition. So what we do is that we give a top-up of around 0.5% of adductor canal block with 10 ml of 0.5% ropivacaine we give a bolus. And of course, multimodal should be adjusted. 30 minutes prior we give a paracetamol, and if ketorolac is not contraindicated, that also given, and so that the first physiotherapy is absolutely pain-free. Unless until you give a good pain relief in the first physiotherapy, then only you can win the confidence of the patient. Cardiology review is must actually. Post-op, we do a post-op echo on regular basis. These patients. So post-operative, we will do on second day or on the third day. If some post-op issues are there. Otherwise, we'll go on the second day. We'll shift the patient to the room. Even in shifting the room we'll continue the adductor canal catheter for 2 to 3 days. And next day onwards, what I do is that around 0.2% ropivacaine, we give it a 5 ml per hour as a continuous infusion. And here also, every physiotherapy, we give an analgesics bolus dose for physiotherapy. And post-op thromboprophylaxis in our institution, we give aspirin 75 milligram for 6 weeks. At least the recommendation says that the ACCP and American Orthopedic Association recommendation accepted the aspirin here, and the orthopedic associations there with the aspirin. But anyway, at least either oral oral anti-prophylaxis, thromboprophylaxis agents like rivaroxaban or what we are using, at least you should give it 15 days. Last few slides. Actually, I just highlight some of the pain management, how we should give the pain management in a total knee replacement. That is very, very important here. And again, this is an excellent article here in tutorial 448 in our WFSA. And you can see that this is the anterior portion of the knee. We have a nerve to vastus lateralis and nerve to vastus intermedialis and nerve to vastus medialis. Here we have the saphenous nerve. Of course, we have infrapatellar branch of saphenous nerve. This is infrapatellar branch of saphenous nerve comes and supplies the knee. And of course, we have a superior superolateral genicular nerve. It's a branch of this is nerve to vastus lateralis intermedialis is the lateral portion, and they are supplied by the femoral nerve. They are the branches of the subfemoral nerve, and suprolateral genicular nerve. It's a branch of common peroneal nerve. Infralateral genicular nerve and recurrent branch of common peroneal nerve. It's this is again the branch of common peroneal nerve. And here on the medial side, mainly the femoral nerve is supplying the several articular branches are supplying the medial side, and in the lower portion we have this is the infrapatellar branch of saphenous nerve, and of course inframedial genicular nerve, and actually this is a tibial nerve. So we have actually major nerves in the posterior portion. Of course, we have obturator nerve, tibial nerve, and common peroneal nerve. So we normally have femoral nerve, articular branches, and common peroneal nerve, or mainly the tibial nerve and tibial nerve, common peroneal and tibial nerve. Mainly the tibial nerve is the major one. And in our analgesia strategy, what we do is that the motor sparing blocks. In anterior knee, we can have a femoral triangle or adductor canal block. There is a little controversy on that issue. Adductor canal, pure adductor canal block, whether we need a pure adductor canal block or a lower, that means a distal femoral triangle block. Anyway, either femoral triangle block, distal femoral triangle block, or adductor canal block is used for the anterior knee pain, and the posterior knee we need a IPAC. That means IPAC is nothing but infiltration between the popliteal artery and capsule of the knee. I will show you the ultrasound sonoanatomic picture. Of course, the popliteal plexus block anyway, and the tibial nerve block. At least we can give the tibial nerve. Why the tibial nerve block? And I used to give the tibial nerve block. Actually, this is IPAC is designed by the Sajeesh, and he himself previously used the tibial nerve. I started using tibial nerve block from his opinion, and once he started coming up with IPAC blocks, and we started using the IPAC for the posterior knee. And of course, the tibial, why we are giving the tibial nerve block is that the majority of the lower portion tibial posterior knee is supplied by the tibial nerve. And if you give an anterior adductor canal block, we block the saphenous nerve, and nerve to vastus medialis is there, and of course the posterior division of obturator is there. And then the tibial nerve, we can block tibia separately. Why we are giving the tibial nerve block is that if you give a common peroneal, sciatic block, the full sciatic block, the problem is that your superficial peroneal nerve is blocked, and in the postoperatively patient have a foot drop, and surgeon is not acceptable for most of the surgeons, because they have all other reasons to worry about plenty of reasons to worry about the foot drop with a surgical problem. So what we manage is the isolated tibial nerve block. Of course, LIA, local infiltration analgesia, we can with around we call it as an analgesia cocktail. That's with around 150 ml of 0.5 ropivacaine, and many centers they use different things, adrenaline, ketorolac, and clonidine, some other drugs we also use, and surgeon infiltrate. The problem with LIA is that they give an excellent analgesia, but it is maximum we'll get around 10 to 15 hours what we get. So this is a IPAC. This is a lateral portion of the knee, and just frog position, and the lateral probe is placed is low frequency probe, and we introduce this femur and popliteal artery. Actually, this is an infiltration between the knee capsule and the popliteal artery. So we'll just, here comes the article, and what I prefer is the posterior approach. Here we can see the common peroneal nerve also. This is a tibial nerve. We can see the tibial nerve. This is the popliteal artery, and this is the femur. So it injected in between the femur and the popliteal artery. That covers the posterior portion of the posterior portion, and of course this is an adductor canal block that all of you know that this is a nerve to vastus lateralis, medialis, and of course this is a saphenous nerve. And so the postoperative pain, the thing is that the common peroneal nerve component, that supplies the lateral portion, around 20% of the innervation is by the common peroneal, and normally we miss on our strategy common peroneal, but in a postoperative, on a practical point of view, it's not that much important. We can manage with multimodal analgesia. So we give a IPAC, adductor canal spinal, tibial nerve or IPAC, plus adductor canal catheter, and the post-op analgesia, we will give you adductor canal catheter, and we will a good 2 to 3 pain score with the adductor canal continuous catheter. Of course, we use the multimodal analgesia. Thank you. We can move on.
Thank you, Dr. Sajeesh, for the very practical and down-to-earth talk. I'm sure many of us will go back enriched with all the knowledge with these blocks. And they are very practical blocks that you have shown us. Now, I'd like to thank the organizers for giving me this chance to chair this session. It's very interesting to note that 50% of perioperative mortality is of cardiac origin, and most of these cardiac events occur within the first 48 hours. So we should be vigilant throughout the procedure and post-op to prevent any untoward events. And most of these perioperative MIs are common in patients with ischemic heart disease, and they present very atypically. And usually they do not have any symptoms, and most of them are non-STEMI. And perioperative MIs have a mortality right up to 50%. So we as anesthetists, it is our task to identify, to prevent, and to treat these perioperative events. Now, Dr. Sajeesh, my first question to you is, how do you recognize and manage a perioperative MI?
The point is that perioperative MI, the most of the cause of perioperative MI is, of course, the supply-demand mismatch rather than this plaque rupture and all. So actually, this has got a good prognostic value also. But of course, we can even detect it with an ECG will be a very difficult one. We can detect either by the clinical one, ECG changes, and of course the biomarkers. We have the very clinical point, clinically in a patient on spinal anesthesia and all, maybe some patients they may present with complaint of chest pain or something, but in the most of the time the problem with severe diabetes and all of the old age and all may be a silent one. And ECG also, when we don't get a hyperacute ST elevation or something, we may miss that also. So the biomarkers and troponin, Trop T is the biomarker we use, and Trop I is the classical one we use. And around 24 to 48 hours, it will be raised. Especially the post-op and all, post-op patients, as Madam rightly said, we need at least around 72 hours we have to monitor for this thing, post-op, any post-op ischemic event or something.
How do we, what is the role of giving, how do we treat hypotension and tachycardia?
Can I just interrupt?
Yeah.
Persistent hypotension, that I think should make us aware of that there may be a cardiac event happening, which is not responding to, like we should suspect that there is a cardiac event happening. Persistent hypotension, which may not respond to our usual measures. That may be an important indication for, or some arrhythmias or severe bradycardia. Even a fall in SpO2, I think, is a good, if you rule out other causes. Am I clear, or is there some internet? No, is there some internet? I'm not sure with them. Yeah. Okay. Yeah. Okay.
How will we treat?
Dr. Mariam, I'm sorry, I interrupted. Yeah.
No, not at all. So how do we treat an intraoperative or perioperative MI?
Pardon?
How do we treat if the patient has signs of tachycardia or ischemia? How will we treat?
And of course, that depending upon the patient's what kind of exactly what kind of a myocardial event this patient is having, or we can manage accordingly. And either we give, normally we given medicines, we can give some cardiac medicines actually, and either actually we didn't given any interventions, such as PCA or any angioplasty interventions we didn't done, and our experience is not there, and most of the time we will manage with the angina measures.
Yeah, probably they may manifest just as tachycardia. That must be that we should treat with beta blockers.
Exactly, madam. The point is that the key factor in an intraoperatively for this is a supply demand mismatch is mainly it's a triggering the cardiac event or an ischemic event. This is a supply demand mismatch. The main reason is tachycardia is the main reason. That's why we start on a beta blocker also in the patients for the better control of the heart rate. And of course, as madam rightly said, it's a hypotension also. That also we have to, anyway, you have to maintain the hemodynamic status. Tachycardia is the very key for trigger.
This one more point in this. Pardon? Did you say anything, Dr. Sajeesh?
No, wait.
Okay. No, especially in this patient, like because she has anemia also, so that will confound the worsen the situation. So there is a question in the chat box. So because we're talking of anemia, I'll just read that question. Is there any guideline regarding preoperative minimum hemoglobin before taking up for surgery? And is there a role of intravenous ferritin to build up hemoglobin before taking up for planned surgery? Dr. Sajeesh, would you like to take that?
Yeah, madam. What we personally do is we don't use intravenous ferritin. Actually, if there is it's highly elective procedure. So if anemia has to be corrected, we use an oral ferritin and all other measures, anemia medicines, ferritin and all. We'll give it and control the hemoglobin. And of course, if we need, we give the blood transfusion. We don't, in our institution, we don't give an IV ferritin, intraoperatively IV ferritin, correct?
Yeah. Okay. And what level would you like to?
We'll keep it around 8. That's as I studied in the cardiology guidelines on the saying is that, and even in the, I think it's in the Brown Wald said it should not be less than 7. That is, I think it should be more than that. What we keep is that is 8, minimum 8.
And according to, I think, 2012 blood transfusion guidelines, they say that if the HB is in a non-CAD patient, HB below 7 can be given blood transfusion. Yeah. And in a CAD patient, also they say not a very liberal strategy. They say 8 in a CAD patient. And what they say is that in a CAD patient, if the patient does not have any symptoms, then you need not transfuse if the HB is above 8. Like maybe in the mild anemia range, you need not transfuse unless the patient has symptoms, like some angina or some other symptoms like that.
Exactly.
So, your take on that, Dr. Mariam?
Madam, anything to add, Mariam, madam?
Yes, I think we should keep it just like what you said, just around 8.
Yeah.
Previously, we used to take it as 10, but
10.
now it's
around 8. Okay.
So what is
Vandana,
you go on.
Yeah, then about the management options, like definitely we all go for regional, but your personal, I'm sure, is choice is regional only. What do you think are the problems with general anesthesia?
General anesthesia, actually, it's not contraindicated. General, actually, it's not contraindicated. No, the issue. But in our center and our choice is at a regional. That's what the thing. But then contraindications, absolutely, there is no contraindication for the general anesthesia. The point is that most of the time the patient is very anxious and apprehensive on this thing. If you have a discuss and communicate with the patient and discuss very well, and even we do when sitting spinal what we give, actually we don't sedate and give, we communicate, keep on communicating with the patient and all, where they are very comfortable with the regional techniques. And another point is that if it is a contraindication indicated for the regional anesthesia, that is a bleeding issues, it's a high INR or some other things, then it should not be, it's a highly elective procedure. So we have to optimize and everything, and then only we can take up this. There is no reason to avoid regional anesthesia except the patient choice. If a patient wants the general anesthesia, we can definitely go for the general anesthesia. Absolutely no issue, no problem. But the thing is that in our experience, we never give a general anesthesia patient for general anesthesia and this thing replace.
I think none of us do. Yeah.
That's a big, actually, big interaction. Actually, even the day before the surgery, also we keep on interacting. It's very, very Another very important thing I see is that most of them are aged patients. Minimum more than 50. Even especially the hip arthroplasty and all, we use GI. And almost some of them are very young patients with a vascular necrosis of the neck and all. But in a knee arthroplasty, most of them are done more than 50 years and all. They are not that much apprehensive and all. They actually they communicate. I mean, they cooperate with us very well.
Good post-op analgesia also prevents DVT, so it is definitely advantageous to give regional to these patients.
Dr. Mariam,
analgesia is very key actually. The thing is, and what I personally do is that I give a separate instruction for the physiotherapy, analgesic strategy for the physiotherapy. We keep our, at least for 3 to 4 days, 3 days minimum, we will give analgesia through this thing, adductor canal catheter, and on top of the medicines for the analgesia. That gives an excellent patient satisfaction. The dictum is that it should not be more than 4. Pain score should not be more than 4 at any point of the time. That we'll give. Of course, the multimodal we can manage with the multimodal. And the thing is that most of the time, except we are using fentanyl on the infusion, otherwise we don't use opioids in the postoperative period actually in aged patients. Normally, we don't require even.
Yes. And about this, just wanted to about the different opinions regarding antihypertensives. Telmisartan, again, I know it's a controversy. So this patient with a BP of 160, 100, would you still want to discontinue telmisartan, or you would like to continue telmisartan?
No, discontinuing the telmisartan is the intraoperative. We are using a regional anesthesia and all, and we expect hypotension and all. The managing with vasopressors and
will be difficult,
like long-acting. OHAs, like OHA, it's a long-acting antihypertensive. That's why we are using for the better control of this. We are not using the general anesthesia. Regional anesthesia, there are wide fluctuations we can expect actually, but that should be kept to minimum. That's why we stop telmi.
In spite of 160, 100, you would like to? Pardon?
Somebody in the chat box has asked a question. Can we give vasopressors if there is hypotension? That's a question.
Yeah. Yes, what I personally we use is the phenylephrine for intraoperative hypotension. We use with the incremental dose of phenylephrine. That's what we use.
That's what is recommended everywhere.
That is better.
Yeah. Then about beta blockers, also the recommendation is that it should not be started on the previous day, right?
It should not be started on the previous. If you want to start, it should be started at least 24 hours prior actually. Just just a day before the surgery, if you start a beta blocker, that's not advised.
Okay. So according to, I think, 2014 ACC/AHA guidelines, they have defined this, that we should not start on the previous day. Dr. Mariam?
Beta blockers should be given basically to bring down the heart rate in an ischemic heart disease patient to either low or near normal.
Yeah.
That is the idea of starting a beta blocker, and I think it should be started.
Earlier,
The
but
point
not
is
on the previous.
we expect the hemodynamic fluctuations is immediately after the spinal anesthesia, one thing. And second thing is, bone implantation syndrome, we can have some hypotension. And third thing is the release of the tourniquet is a time when you can expect something. And another fourth thing is, as Madam said, in the any intra-op events, actually cardiac even when myocardial events happening, then of course we can expect this. So you should be very vigilant in ischemic heart disease. It should be taken lightly in the big, because once it's drastic reduction in the hypertension, blood pressure, and bradycardia, then resuscitating will be very troublesome actually in this kind of patients. Should be kept at optimum, and should maintain the stability, hemodynamic state. That's very key. And with the regional anesthesia, with maintaining the hemodynamic stability, it's a little challenge, and it's an art actually.
Sure.
What are your anesthetic concerns in patients with ischemic heart disease?
Madam, sorry.
Your anesthetic concerns in a patient with ischemic heart disease.
Exactly. That my point is that the blood pressure and heart rate should be kept optimum. Pre-op level should be kept, and we will maintain that the entire procedure. That is the key thing in intra-op management of ischemic heart disease patients.
How would you like to optimize these patients pre-operatively?
Pre-op in this patient, the point is that we already discussed the two major things. That's an anemia, and the other one is one patient is on antihypertensive. So the stabilize with we already discussed that in the telmisartan we stop, and we know. But atenolol, the case scenario what we given is atenolol is not a good beta blocker. Actually, we have a better specific bisoprolol, and we have good things actually. Nowadays what we use. We don't use atenolol, but anyway, the good beta blockers we have that actually beta blocker is very key in ischemic heart disease patients. And any other agents, even telmisartan.
Probably if we have time, we can improve the nutritional status if required of the patient. And
what about risk stratification pre-operatively? Risk stratification.
Risk stratification, Madam, what you are?
How will you find out which RCRI and METs and all that we should calculate and find out?
Yes, exactly. The point is that the functional capacity assessment will be very difficult in this.
Difficult in this, but you can.
The point is that they have a bilateral OA. The activity will be limited. Yeah, another thing is we have the patient is having anemia also. The functional capacity will be assessing the functional capacity very difficult in this sense. But anyway, we expect that it's more than 4 METs for them, more than 4, because the routine activity is not
RCRI.
Okay.
RCRI.
Okay.
Yeah. And recent, actually, there's a journal article in British Journal, which has just come out. It's still in print, but you have it on the internet. It says that if you combine the values of biomarkers along with RCRI, it gives a very good predictive value regarding the regarding how the patient will respond to your anesthesia, the risk of the patient. So that's what is mentioned. The high sensitivity cardiac troponin, that's what they've mentioned in particular.
Okay.
They combine, then it gives a good indication. And you can even use it to compare the previous values. Post-op, if you suspect that this patient has a cardiac event, you can use it to compare the previous value. So they say you can start it. Yeah.
Pro-BNP.
Pro-BNP.
Any other?
So how are we for time? Are we overshooting our time? Would you sing on DAPT, the dual antiplatelets?
The thing is that even after the 6 months, what the recommendation is, after the 6 months, we can clearly stop the If we aspirin and everything, we can stop actually. The point is that by the time it is epithelialized and is no issue after stop. After the 6 months, we can comfortably stop actually.
Yes.
And the point is that at the cardiology point of view, they recommended stopping the aspirin should be stopped around 7 to 10 days, and the clopidogrel and other things should be 5 to 7 days prior to you have to stop it. But our regional anesthesia, all other recommendations, we can continue aspirin. Actually, we don't have a.
Your patient is low dose aspirin, right? 75 milligrams can be cut.
Yeah. And do you think bridging is required? If you're probably, suppose you're using stopping clopidogrel in a patient, not in this patient, any other patient, do you think bridging is required in all patients?
The point is, in patient is on total knee replacement. The point, its answer is very clear in the sense it's highly elective procedure.
Yeah.
So we'll take up only after the 6 months, we can comfortably stop DAVP. We can stop actually, but we take up only after 1 year. Actually, minimum 1 year we will keep. So then elective surgeries. By the time we can comfortably stop all these things, we don't need a bridging.
But no, I'm not asking about this patient. Routinely, do you need? Suppose there's a patient whom you have stopped clopidogrel. Do you practice bridging routinely, or
no? We don't.
Practice. Okay. Anything else, Dr. Mariam?
What about post-operative management? What are we supposed to look for in this patient? How many days will you put them in the ICU? Is it mandatory to put them in the ICU?
No, madam. The point is that we will keep for just 1 day. We will keep it in the ICU. The problem is that the old age patients, if you keep more than 1 day, they have a ICU psychosis, and the time orientation will be lost, and the big problem. The patient will be very comfortable on the second day. They will be returned restless, and as early as possible, we will shift the patient to the room and socializing with their relatives and all. We allow it. But the point is that if some intraoperatively event like hypotension or something, some events happen, then we keep it 1 more day. And the key is the pain management. So we keep for 1 day is mainly for the, especially the ischemic heart disease patients, for the monitoring the hemodynamic status. Monitoring is the one thing. Second thing is to provide better pain management. And even after the first physiotherapy, if you give an adequate pain relief, then the patient is comfortable, and we will shift the patient to room. Of course, in this patient, we continue the monitors in the room. Actually,
you monitor ECGs and all in the room.
Right.
Okay. And what about serial troponins?
Routinely, we don't do actually, unless there is any indication. Otherwise, we don't use. Routinely, we don't use.
Okay. And how's your tranexamic acid use? Are you giving to all patients?
What we personally give is 10-20 milligram per kg, and maximum of 1 gram. Maximum 1 gram we give, and I personally give just prior to the tourniquet release we give, and some surgeons they insist just prior to the incision they will give actually.
Yeah, there are some people who have asked me, like, this patient, if the patient is on antiplatelets, risk of thrombosis with tranexamic acid. So there is some confusion sometimes regarding that. There are some surgeons who are a little apprehensive about giving tranexamic acid. They feel that there might be some clotting issues, but I think that is not a concern. Actually.
It's not a concern, and a few articles are the good articles also there on studies on this thing, tranexamic acid in ischemic heart disease patient, both total knee replacement. It's not that much difference actually. It is not a big concern.
Yeah, not a concern, especially because anemia. I think it will help to reduce the blood loss.
Normally we at least we can expect around 1.5 to 2 liter. We can expect blood loss. Keep it to the minimum level is the key, rather than push. Let down the blood and replacing it with the blood components. We'll keep it to the minimum. Loss should keep the minimum. That is that should be the strategy. There the Tranexa helps.
Any concerns about stent restenosis?
stenosis, actually, that's what recommendation says, that after 6 months, the stent is epithelialized. So there is not a major issue even if we are stopping the double antiplatelet therapy. That's not an issue. And of course, we are keeping it around 1 year. That's not but of course, stenosis issue is not pertaining particular to this thing, our anesthesia or surgical stress. That can happen at any point.
And it even some other vessel also might get affected in this 5 years that have passed.
And the thing is that some studies and says that around 2 weeks, cardiovascular complications is very high in ischemic heart disease. But the point is that if they survive the 2 weeks period and all, then the overall their physical activity and cardiac status also will improve, because of their increased mobility and control of hypertension and other things, physical activity and all. But initial 2 weeks is a key, actually. That there is an element of risk. The risk is there, definitely is there.
Yeah. So anything else, Dr. Mariam? Or
I think we can wind up.
Yeah, because I think we have overshot our time also. So thanks to all of you, and thanks to the organizers for having me here. Thank you, Dr. Sajeesh, Dr. Mariam, and all those who are present here. So,
yes, nice to interact, Vandana Madam and Mariam Madam. Thank you.
Thank you very much. Yeah.